Yes, go for it.
Okay. All right. Well, welcome everybody to this coalition conversation. I'm Alice Bonner. I chair the Moving Forward Coalition along with our director, Isaac Longobardi, and we are thrilled to be here today. This is a wonderful and exciting event for us. There's a lot of familiar faces on this call, so we appreciate that, and some new faces as well. We actually sold out for this conversation today, so it, I think, speaks to how important this topic is, the topic of mental and behavioral health, and how we work with individuals in nursing homes who are living with a variety of opportunities and challenges as well. But you know, we really have an amazing panel of speakers today. They're delighted to be here with everyone. Again, you know, nursing homes are an interesting topic these days. Sometimes they get overlooked in big conversations about, you know, master plans on aging or multi-sector plans on aging. But, you know, it's really important. And in some studies, about 85% of people who are living in a nursing home may have a mental or behavioral health diagnosis. If you've been on these calls with us before, you've also probably heard us talk about the NASEM report, which is the National Academies of Sciences, Engineering, and Medicine report on the national imperative to improve nursing home quality. So there was a lot in that 600-page report that was very specific to mental and behavioral health, and what are we doing about individuals who, you know, need our support. Because they have some, you know, again, some opportunities to improve their quality of life related to those conditions. So last year, you know, I was fortunate to collaborate with the people who you're going to hear on our panel today. And we co-authored a paper for the Gerontological Society of America that was published. So we can share information. We'll certainly share information from that paper today, but we'll also share a link so that you can look up and find more information if you'd like. It had a lot of detail in it. So again, just we really look forward to, at the end of the call, we're going to try to leave some time for discussion because we want to hear from as many of you as we can on this call. We want to hear about what you're seeing out in, you know, your world, and what opportunities and what programs you've implemented, what you're looking to learn about, and go from there. So without further ado, I want to introduce our panel for today, and I'll give you a brief introduction for each of the speakers. A longer introduction was on our website, and you probably saw it when you registered. So we have Alexa Fleet. She is a social gerontologist pursuing her PhD in gerontology at the University of Massachusetts in Boston. And her current focus on her work is how to make age-friendly systems more behavioral health supportive, and vice versa. Paige Hector is a consultant and nationally recognized speaker with over 25 years experience in post-acute and long-term care settings. And Paige specializes in person-centered trauma-informed care, nonviolent communication, advanced care planning, and sustainable process improvement. We have Mercedes Byrne-Klug, who is a professor at the University of Iowa School of Social Work, and much of her scholarship focuses on enhancing the role of nursing home social workers. She also works in the area of proxy medical decision-making in the nursing home context. And finally, we have Evan Pliss, who is a clinical psychologist and board certified in geropsychology at Massachusetts General Hospital. And he's an assistant professor of psychology at the Department of Psychiatry at Harvard Medical School. Evan co-directs a new clinic providing specialized psychotherapy for caregivers, dementia, and other neurologic disorders. That's happening at MGH, and he supervises clinical psychology fellows at Spalding Brighton Skilled Nursing Facility. So as you can tell, we have some very experienced people and passionate people who've come together today for this call. So we will just dive right into the subject matter, I think. And you know, to start off with, I think maybe we'll turn to Alexa and Mercedes, and maybe you can frame for us and for everyone listening today why this is such an important issue. What mental and behavioral health conditions, you know, are prevalent in nursing homes, and then maybe say a little bit about how the population's evolved over time and is expected to evolve going forward. So Alexa or Mercedes, who would like to get us started with that?
I can jump in. I just want to put things into context. When most lay people think of nursing homes, they're thinking of places that serve older adults and that people live there. They are admitted to a nursing home and they live there until the end of life. That is no longer the situation of the 15,000 nursing homes in this country. In fact, living and working in a nursing home has become more complicated than ever before because the nursing home staff is trying to do the almost impossible. And by that, I mean working with so many different populations. We're seeing a growth in subacute. So people go to the hospital, they have a hip fracture, they go to the hospital, they come to a nursing home to get rehab, and they go back home. Or they have a stroke and they go to the hospital and they get rehab at the nursing home and then they go back home. That's a whole different kind of culture and subculture of care. Then you have people who go to a nursing home at the end of life because you can get hospice services there or other kinds of services there that aren't going to be available in that person's home for whatever reason. And then you do have long care populations. But what we're seeing is among that long-term care population, a growing percentage of people under the age of 65. And it's about 17%, 17 to 20% of nursing home residents, depending on where you live, under the age of 65. And many of those people in particular are dealing with serious mental illness. And Alexa, do you want to say a little bit about what are different kinds of serious mental illnesses?
Yes, ma'am. Thank you so much. And right, like she had mentioned, now there's a lot more Medicaid beneficiaries between 22 and 64 entering nursing homes, with 50% of those individuals on antipsychotics and ending up in the nursing home. And when it comes to serious mental illness, like you just brought up, the prevalence of individuals with SMI in nursing homes has increased 77% in the past decade. So there's a huge influx of serious mental illness, and that is in addition to the cognitive impairments, depression that is common, the behavioral and psychological symptoms of dementia, anxiety disorders, and delirium that are already clocked and very prevalent in nursing homes. And in general, 80% of nursing home residents have a diagnosable psychiatric disorder in one of those areas or in multiple. But even though it's so prevalent, fewer than a fifth, receive treatment from a mental health professional.
Mm-hmm.
And people who are challenged with SMI, and that's including people that are having psychotic episodes, people with schizophrenia, people who are having delusions, people with hallucinations. Caring for people like that can be very difficult in a group setting because the behaviors impact, of course, the person who's experiencing them, and they may be suffering from those experiences, but it also is impacting the fellow residents, and it impacts the staff. So having a group setting that contains people with SMI, you do need to have specially trained people, and you want to set up a good social environment. And unfortunately, just as this population is growing in size and number, and older adults have plenty of SMI also. It's not just people under 65, but that's one of the big changes is the under 65. Just as this population is growing and these needs are increasing, we're also seeing problems with community-based services. So if communities had more services to help support people with serious mental illness, then we wouldn't have as many people with serious mental illness in the nursing home setting, because now nursing homes are becoming a concentration for people with serious mental illness.
Right. I think that was one of our next questions, which you led us right to, which is, why do some of these individuals live in a nursing home and receive their services and support there as opposed to being in the community? How does it differ if someone with SMI is living in the community versus in a nursing home? Alexa, you want to take that?
Yes, and just look at the history of how we even came to this dire circumstances where nursing homes are the de facto place of residence for individuals struggling with SMI. But because the deinstitutionalization movement, where we de-invested from institutions that could be supportive for or focusing on mental health and behavioral health, in favor of community-based services, but those community-based services and infrastructure and investment never came. So we're kind of catching up to try to build the community supports and services that we need to help individuals thrive, which is unsatisfactory in many places in the United States.
And most people would prefer to live outside of an institution, right?
Yeah,
I mean,
we do hear that on
Yeah.
surveys. People do say that,
Sure.
right? Right. One of the questions that came in from Dakota, and maybe is relevant to this, and any of the speakers can jump in, is that, you know, are nursing home residents eligible to receive county behavioral health services, or must they use nursing home behavioral health staff? I don't know, Evan, that might be something that you want to jump in on.
Yeah, I'm pretty sure that they can still receive outside services. A lot of nursing home residents or assisted living residents also will receive behavioral health billed through Medicare Part B.
Mm-hmm. Yeah, nursing homes are required, as you know, most of us would know from the regulations, you know, that they have to contract with a mental or behavioral health, you know, organization for any residents who live there who need those services. If it's a really large nursing home, is it possible that they might have someone actually on staff who would be able to meet the needs? I think the answer is yes, it's possible. But I think that the more common model is around the country right now in the US is that they contract with a service for that. And I just, before we move on, maybe one more question, Alexa, for you and Mercedes, which is, you know, what are the issues in nursing home care of people with, you know, SMI and other conditions? And Mercedes, you said it, you know, a lot more people are getting older and growing older who've lived with SMI for their whole life. So what are the typical issues that any of us might see in that population?
Oh, well, if you've lived 50, 60, 70, 80 years and you've had a lot of issues related to serious mental illness, sometimes that wears the family down and your support system down, because it can be exhausting trying to provide that kind of support. And the kind of support that people need really sometimes you do need medications, you need some psychosocial support, emotional support, housing support. So if with the serious mental illness, it's called serious for a reason, lots of services and supports in place can really help a person live a more full life. But absent those services, it can be difficult to coexist with somebody with serious mental illness. They're unpredictable. Their behavior is unpredictable. They may lose touch with reality, which can be very disconcerting to fellow residents and to the staff as well. So it can be difficult to have people with serious mental illness living in your facility.
Mm-hmm. And there's also the cognitive issues, because there's a lot of coexistence with individuals who are living with dementia or other cognitive changes too superimposed. Alexa, what else would you add to that?
I think there's a huge tension at the nursing home level of, are we trying to keep individuals with behavioral health issues or others like SMI together? Are we trying to find harmony and treatment that is not disruptive to all the individuals in a nursing home that need different care? And also, what kind of hours do individuals with more serious mental illness need from the staff, that when nursing homes are already have huge staffing gaps and training gaps, and it's just it's very hard to treat mental health care in nursing homes, but not that it's not possible and we're not improving. One of the papers in 2021 by Stephen Bartels looked at a couple of different models that are used in nursing homes across the country. And so we have psychiatrist-centered, nurse-centered, and then the multidisciplinary team models. And so those are kind of growing as models to navigate the treatment for behavioral health.
Mm-hmm.
Good points. And, you know, the staff deserve access to information and training on how to work best with people with serious mental illness. And if we aren't supporting our staff by giving them that information, it's far more difficult to work in the nursing home setting. The issue, Alexa, you were right in bringing up staff shortage issues and staff turnover issues. And so it's really a difficult situation to continually update and keep training people when there's almost a revolving door, especially with the direct care staff. So there's many things that do need to change, but I think the first thing we need to do is recognize that people with serious mental illness deserve a level of care that isn't always available at all nursing homes, but it could be.
Mm-hmm. Yeah. And, again, just for everybody to know, so we have about 70 people on this call, and a lot of them are clinicians. We have some people who are direct care staff members. We have some people who may be owners. We have nursing home residents. A few of our steering committee and other members are on this call. There's some advocates, probably family members. So it's a broad and diverse group, as well as researchers. So hopefully this information is helpful. But again, we have some questions coming into the chat, which is helpful. So Isaac put another question in. Do we have recommendations? Do you have recommendations on where to start with training nursing home staff members regarding SMI? So I think you guys were just both speaking to that. What would you say in terms of, any recommendations of specific programs or places to go for that? And Evan or Paige, you can jump in here too. I know everybody on this panel has done this work.
I mean, I always find that just helping staff kind of understand the attributions of behaviors that they're seeing can go a really long way. I think a lot of times what we see is there are some challenging behaviors maybe that occur with a resident with SMI. They get labeled by the staff, and then that changes the way that the staff interacts with the resident. And so really helping staff to kind of attribute what they're seeing to to the illness, and then triggering some self-efficacy in them that, okay, now I know how to manage this because I understand what's going on here. I think that's a really good place to start with staff.
Mm-hmm. And also Deanne Walters chatted in a link. So that's another suggestion. And by the way, anybody on the call who's got ideas about this, feel free to chat them in for your colleagues, because again, that's one of the reasons we have these calls is, there's a lot of information out there that you all have that you can share with one another. Alexa put in an ombudsman, a link from the long-term care ombudsman program as well. Before we move on to the next topic on policy, just want to invite Paige or Evan. Is there anything else that you would add about, the population of individuals who are living in nursing homes and, anything else about the issues related to, have we covered it adequately so far in terms of, we talked about training, we talked about staff self-efficacy, that was great. We talked about the challenges of doing everything else, plus the integration, of really good work to support people who have lived with SMI for a very long time. Anything else that you would add? And Paige, you could add anything about trauma-informed care that you want to just tee up here. I know you're going to talk about it later too.
Yeah, I will in a little bit, but I think I just want to tee up on something that the correlation when we have younger adults with serious mental illness living in a nursing home, a collaborative or a community type of setting, and also the dynamics of staff. And so sometimes to really understand the psychosocial components, not just for the residents and patients, but also for the staff, because sometimes we might have a resident that is very similar perhaps to a parent or an adult child, or the relationships and the links. And I'll talk more about trauma in a little while, but I think that that's very important for us to understand as well, that we are talking about a very unique, very special environment where people can live for many, many, many years, and where people can work for many years. So it's like having people in your own house and then people working in your own house all the time, and imagining all those dynamics. So that collaborative environment can be really, really challenging.
I think that's great. Thank you, Paige. And there are two comments in the chat. One is from Donna, and she said, how do you get leadership to understand that the training of staff related to SMI is not the same as for staff who are being trained in dementia? And I know any of you could answer that, but Evan, I know this is one of your areas of, dementia, delirium imposed on dementia, and SMI and dementia coexisting. And thoughts on a response for Donna?
Yeah, it's such a good question. And I think there are clear differences, you know, and the context of the illness and, you know, symptoms are different. And I don't know that the training is completely different. So it's challenging because a lot of the same, you know, kind of compassionate care, understanding behaviors are going to translate. And there's going to be subtle differences. So, you know, so in how to communicate that to leadership, I don't know. I was just shaking my head because I think it's such a good question that I think we actually need to do a little bit more work on.
I would also add to everything Evan and Paige just said that it's important to raise this issue, right? So none of us should assume in any, and we've all worked in nursing homes at different points in our careers, and some of you are working in them right now, but we should not assume that there is a certain standard amount of training that's enough around either dementia or, you know, SMI or any other, you know, psychosocial issues. The training around dementia is also very limited, especially for certified nursing assistants. So anyway, I think you're raising a really good point, Donna, and we need to bring it up and go forward.
Another thing speaking to the administrators, when your staff feel more competent, they're more likely to stay. There are many things that make for a good work environment, but having a sense of agency and a sense of control and a sense that you're doing a good job those are all important. And so when people have the right kind of training and knowledge to interact well with residents and with families, both of the families of the person with serious mental illness, but also the other families who are visiting somebody who doesn't have serious mental illness, who doesn't know what's going on with that person down the hall who's acting delusional. So when we can provide the kinds of training and support, it's not just information, it's also support to those staff who are working this very difficult job that lowers turnover and that can help the whole system. So there is also, there's something in it for everyone when we all provide good care, but it costs more time and it costs more attention and it costs more money to provide the best kind of care, but we need to decide, you know, are we in this to provide good care?
Right. Great point. So I hope everybody is taking a look at the chat. There's some really good information. So Kathy is talking about the Center for Excellence in Behavioral Health, and we've worked with them. We've spoken to them. So Kathy, thank you for mentioning it. She also put their website, their link in there. They have a lot of really good resources and supports to consider. So it's one really good national resource. Alexa chimed in with mental health service delivery models in nursing homes, a review paper, if people want to take a look at that. And Nancy Tutors, who works with Nadana and other organizations, talked about, you know, a particular group that comes in a couple of times a week and meets with residents. So again, I think people are really chiming in with some good ideas and things that are happening around the country. And we put in is that the Stephen Bartels article, I think, thanks, Isaac, that Alexa mentioned. So this is great. Keep putting ideas in, and this is how, you know, this is how we make connections and can network across the country. Thank you for spelling out Nadana. And I think we'll move on into the next topic area in general, which is, we'll keep this part of the conversation going too, but we wanted to talk about policy regarding mental and behavioral health in nursing homes. And I think we'll have Evan sort of lead this off, and maybe you could share, Evan, how, you know, we think policy has shaped mental and behavioral health care in nursing homes over time, for better or for worse, because, you know, we want to be really transparent on this call, like what's going well, what do we still need to do? So what are your thoughts?
Yeah, so as everyone on this call knows very intimately, policy in nursing homes, policy really shapes practice. And so I think a lot of the policy and then subsequent models of practice were really developed in this post-OBRA world. And around mental and behavioral health care, I think the field's actually done a really good job of addressing what are kind of, or were the key concerns to nursing homes. So folks who are cognitively intact, making sure that we have things in place to help that transition and that adjustment and engagement with life. And then same thing with residents who have more severe cognitive impairment. So folks with dementia, again, I think we have done a pretty good job of thinking about, their biopsychosocial well-being and making sure mental and behavioral health policies reflect that. What wasn't really considered at the time, because it wasn't really relevant, nursing homes are not psychiatric care units. So this subsect of mental and behavioral health for treating serious mental illness, I think we haven't really shaped the models and shaped the policies to accommodate that. And I think that when we also evaluate policy, this isn't just a nursing home CMS policy issue. Mercedes mentioned this, it's very much a home and community-based services issue. And so, we can't really divorce those two things and evaluate them separately. If we don't have community-based services for older adults to, live in their home or another community setting that's less restrictive, then they will end up in nursing homes. And so we really need to advance policy in both of those domains. The one thing I will say is, if we look at kind of the Venn diagram of the nursing home and community-based services, we see the PASSAR. And so I think if you're like me, you kind of have like a visceral reaction to PASSAR.
Can you tell people what it stands for or what
Oh
it
my
means?
gosh, you're putting me on the
Sorry.
I don't even.
Alexa's
Yes,
raising.
Alexa, what is
Okay,
PASSAR
okay, hold
stand for?
on.
Pre-admission assessment and resident review.
That's what it is,
Thank
yes.
you, whoever said that. Yes.
So, the PASSAR really was developed to divert people with serious mental illness out of the nursing home setting. But without really robust health and community-based services and this influx of people aging with serious mental illness, it's really just not serving that purpose. It's actually just like screening people in or keeping people in who were ending up there. So the PASSAR is really not functioning the way that it was intended. So I think that's a big policy that was supposed to be a safeguard, and it hasn't functioned that way. The last thing I'll say about the PASSAR is, so I do my work in subacute care. And as Mercedes also mentioned, nursing homes are unique in that you have two very different sectors of healthcare coexisting in one leadership structure. So for a short stay resident, if they're intended to be there less than 30 days, they don't have to do a PASSAR. So a lot of folks with serious mental illness, and I see this a lot in my practice, people with serious mental illness will have a fall, an infection, end up in a SNF for a short stay. And it will become apparent without, when we superimpose medical conditions on behavioral health conditions, now the previous level of care is really not enough. They need more services. And without, those really robust mental health services in the community, folks are transitioning to long-term care. Also, people with serious mental illness, as we talked about, have fewer social resources, fewer economic resources. Those are also predictors of folks who come in for post-acute care, staying for long-term care. And a lot of people are dually eligible. So it's kind of fairly easy for them to have that Medicaid kick in. And then once that happens, now we have to give them PASSAR, and they're already placed. So it's really just not serving that purpose. And I think that's another tension of, there's multiple routes into nursing homes, and the PASSAR is not really addressing all of those.
Yeah, I think it's a great policy issue. I'm glad you raised it. And I know Mercedes has had a lot of experience too, I think, with nursing home social work. And, the PASSAR was also, am I correct, sort of designed to guide the care and support for people who have these conditions in nursing homes so that it wasn't invisible. But again, I don't know that it's lived up to, the intent. I don't know if you want to add anything more, Mercedes, about PASSAR.
No, I think that's enough for that, other than the intention in part was to make sure that people got the right level of care.
Exactly.
That is
right.
great in theory, but in practice, if you don't have options,
Yeah,
then
right.
you're
What
in
are
the
you going to
nursing
do?
home. And so, you know, we also have at least a quarter of our population living in rural areas. And the rural areas have an older age demographic than the urban areas. And so the availability of community services are particularly scarce in rural areas. So the nursing homes in rural areas are really challenged, and then also access to staff and caregivers. So yeah,
Right.
lots to work on.
Right. So we have Iowa and Arizona from, you know, locations of our speakers on this call, and then Alexa, Evan and I and Isaac are all in the greater Boston area. So urban and rural and everything, you know, and suburban, of course, in between. But you bring up a really good point. There are definitely unique issues related to the services that can be provided, particularly in rural areas. So Evan, I don't know if there's anything else that you or anybody else would like to say about current issues that we have that we're all experiencing right now with, you know, mental and behavioral health services in nursing homes that policy changes could address that we might recommend. So thoughts on that?
Yeah, so when I was thinking about this, and you know, I'm a clinical psychologist. I do psychotherapy with folks, and older adults specifically. One of the things that I see a lot of times is people will come in and they'll have this schema of themselves, this view of themselves, and they'll have information about aging, and it doesn't compute because of these biases. And so now we have information as an older adult, and information of how you viewed yourself beforehand. And this is kind of what's happening, I think, with nursing homes. Nursing homes are not a psychiatric facility. That is our schema of nursing homes. That's what we've built our policy around. That's what our understanding is. And nursing homes are housing a lot of people with serious mental illness. So we have this bit of information that doesn't fit with our schema of what a nursing home is. So I think to even get to policy questions, we need to kind of have an end goal. We can either assimilate that information and say, no, nursing homes are not a psychiatric care facility. And so we need policy to divert people with serious mental illness out of the nursing home because it's not intended for that. And we need to focus on community-based services. Or we could accommodate that and shift the way we think about nursing facilities and say, nursing facilities have to be able to accommodate people with serious mental illness, and now we have to think about different models of care. And without that fundamental question being answered, it does make policy change kind of difficult. I know when we kind of sat down and as a team and talked about this, one of the reasons I love working with Alice is you're like forever the advocate of nursing homes, and you're like, we cannot write another thing of like lofty what's wrong with policy, and you know, what if we had, you know, $1 million, what would we do? So thinking pragmatically, and I think kind of two things emerged. One is to address that fundamental issue of our nursing homes to accommodate people with serious mental illness. We need to know the scope of the issue. We have pretty bad standardization as far as reporting procedures, and also even just the way we're defining and assessing serious mental illness. So without really fully understanding the scope of the problem, we can't really address that. So I think that's a huge policy consideration there of standardized assessment and reporting. The other thing is, and we talked about staff training. We're not going to have a mass exodus of people with serious mental illness from nursing homes anytime in the near future. If that ever happens, if I were to bet money, I would say that is not going to happen. This is kind of here to stay. So we really need to equip staff, and that's not just training, it's also staffing levels. We know that people with serious mental illness require more touch points and more touch time. It's also providers, access to behavioral health providers to support staff, because right now we're in this issue where staff aren't really resourced to accommodate, you know, the patients, and there's a lot of implications of that. But I think one thing we learned from COVID is when staff is not resourced to provide the appropriate level of care, that really demoralizes them. And that snowballs. And it also puts them in harm's way. You know, nursing home direct care staff are already 3.5 times more likely to have an injury on the job. And now we're putting them in a situation where they're under-resourced.
Right.
So we do need to address that more immediately.
Right,
And at the community level, some of the most difficult people to provide care for are people with serious mental illness. And so some nursing homes will say, well, we can't provide care for them. And then they don't admit the person.
Yeah, and then where are they, right? Now they're in the
Right.
community without the services.
Alexa, looks like you wanted to jump in.
Yes, also because individuals with SMI have 10 to 20 years of a shorter life expectancy. So they do deserve to be cared for and receive the care and be treated, you know, with dignity.
Right. Well, I want to turn to Paige, who is going to jump in here and talk about some things related to best practices in the future of care to you know, pull this all together. So, you know, Paige, maybe you could say to, you know, the group here, what do you think high quality behavioral and mental health care in nursing homes looks like? Just, you know, from a practice standpoint, how do you think we can get there?
So two huge questions, but I think I want to just say, first of all, that what we're doing right here is we're acknowledging what is. We're acknowledging the elephant in the room. The analogy I use sometimes with staff is we're going 85 miles an hour down the road, the interstate, with 4 flat tires, and we keep having this scarcity thinking of we don't have time to stop. But I'm telling us I want to have a shift of a perspective of awareness around time, that we think we don't have time to do this or we can't do this. But what we're doing now is not sustainable, which we all acknowledge on this call, and it's not working. So I think it's shifting the way that we are thinking about this into a scarcity mode, from a scarcity mode into an opportunity mode. Like, once we slow down, once we begin to say, well, what does it really mean, and really tease apart, what does staff training look like? How do we get there? What exactly do we do? And I think from my perspective, Alice, is that, you know, when I talk about trauma and trauma-informed care, you know, if I pull out the regulation book, which I have sitting right here, and I read FTAG 699 for those of you in the nursing home world, or anything regarding trauma-informed care, it's always towards the residents. But here's the thing. We cannot have a workforce that is capable with the capacity to provide trauma-informed care and be a trauma-informed and trauma-aware collective unless they also understand it for themselves. So we can't expect them to do something for a group of people, especially a population with serious mental illness, until they've experienced it for themselves. So when we talk about, you know, trauma-informed care principles of safety, trust, transparency, collaboration, mutuality, all of these things, I can't expect CNAs and direct care staff to do that for people unless we have it for them. So to me, I consistently come back to, it must start with the staff. Another part of that is I believe very strongly here, the more I do this work around trauma-informed care, and I'll say nonviolent communication, is really taking a very clear assessment of what is our individual capacity. So as each of us as clinicians, whatever your role is, or for whatever you are, individual and collective capacity. So I'm a social worker by training. So as a social worker, what is my individual capacity? But also, what is my capacity? If I was working in the nursing home, it could be the collective capacity on my unit or neighborhood where I work. It could be the collective capacity. These are the conversations we're not having. And just because if I have a chronically under capacity workforce, simply ignoring their capacity, ignoring those limitations, does not make them go away. What is happening is that we are traumatizing an already traumatized workforce, is what is happening. So to me, this issue of trauma-informed care is absolutely paramount, and where we need to begin with that.
Mm-hmm. And you talked about nonviolent, you know, communication also, and you know, that, you know, we need to figure out how to really support the staff right now. There's not only the issues that, you know, you all have mentioned so far, but there's been a huge exodus of people from, you know, direct care jobs and other nursing home roles, medical directors, nurses, social workers, during the pandemic and now the endemic. And so, you know, this has really had a huge impact on the sector, and you know, the staffing issues are quite real, and they've always been there, but they're even more pronounced now. So, you know, again, there's there's just a lot of stress related to the staffing issues, and for people who are owners and operators related to needing to work with agencies that sometimes are charging, 2 or 3 times what it would cost to hire an RN or an LPN or someone else on the team. So I think there is a lot of trauma related to, what staff are going through right now. Other ideas besides, anybody else here can jump in, in terms of
Paige,
how.
will you say a little bit more about your ideas about the opportunity mindset rather than the scarcity mindset? Can you talk a little bit more about that?
Yeah, absolutely. I think it's just, if you guys think about time, so how often do we see it and how often we say, I don't have enough time, there isn't enough time. So the way I conceptualize this, Marcia, is that we have, if I look at my schedule, I have 100% of my time mapped out, right? So I'm at capacity. So when I'm asked, so if I go into a nursing home and we're asking staff to do more or change their workflow or do something different, we're talking to a workforce that is already at capacity. They are already in a mindset of saying, I can't, how can I don't have time for this. And so what I'm saying is, if we can step back a little bit and rethink about this, and so instead of front loading it with so much, keep adding and adding and adding to the workflow, to the expectations and what we ask staff to do, but instead we step back and have a moment of pause and say, if we could release our attachment to saying we don't have enough time, but let's reconfigure how we use our time. Let's reprioritize how we use our time. Let's talk about capacity and what we're asking our staff to do, and that maybe there's some creative ways that we can shift things around. That I believe that we tend to get very stuck in a rut because it's comfortable and it's predictable. And what I'm saying is stepping out of those ruts and being able to look at things with a fresh perspective and a fresh look at things to see that I think we actually have more time than we're giving ourselves credit for. Does that help, Marcia?
Thank you. Yeah.
And I think also, again, there's a lot of leadership programs and QAPI, quality assurance performance improvement programs, that include a real focus on starting by asking the teams of, nurses, social workers, CNAs, others, what they're feeling and what would help them in their work. And, again, that notion of building on what strengths they already have and not adding, not making it feel like, oh, we're coming at you with this new programming, it's going to be great, and we're adding it to what you already have to do. That doesn't work very well. And we know we want to acknowledge, and again, there's 77 people on this call now, so we want to acknowledge how hard people are working in nursing homes. This is incredibly hard work. And I was a nursing assistant when I was in college. I could never do the job now. It's so hard. And being a nurse or a physician or any of the roles. So I would just say it's really, really hard work, and figuring out by starting with some of these programs is really important. I know Nancy Kusmal chimed in. She's one of our Moving Forward coalition work group members, and saying that we can't do trauma-informed care because we're short-staffed, but that becomes a vicious cycle, right? And we've got to stop and take a pause and decide where to go. So I know we're getting very close to where we wanted to be for doing some Q&A, and we've got hopefully people are thinking of some great questions they'd like to ask, because we can have people coming off of mute to actually ask their questions live. But before we do that, Alexa, Mercedes, Paige, Evan, anything we did not cover that you wanted to be sure to touch on here today before we turn it over to the group for discussion?
Well, I would just like to go ahead. I would like to just say that the mental health needs, including the SMI needs, we do need to have more use of nursing homes getting consultant mental health, but we also need to have social workers in the setting, because when you send residents out to get the mental health, it's really easy to blame the resident. When you're in the environment and you see how the environment is contributing to some of the symptomology, you're going to come up with some different kinds of responses. So I would like to encourage administrators to consider getting that social worker right there on your staff to help your staff as well as your residents and your families around mental health related issues, and then do the referrals for the serious mental illness. Yes, that's a special level of of intervention that you do need some special training for. But for the other more, group living situations and things like that, having a social worker as part of your staff, these people are trained to understand how the environment is impacting the person. And sometimes we really do need to change the environment. And there are certain things that can be done at the nursing home level, at the nursing home neighborhood level, that can really make it a much more pleasant place to live and to work.
Right. And what I love about how you just said that, Mercedes, is you said it with so much passion, and you encouraged everybody on this call to do what you have done and many others on this call have done, which is to take action. And when the status quo is not okay, we have to take action. We can't just sit back and, oh, the pandemic, oh, the nursing homes, oh, we're underfunded. All those things are true, but that's the situation we have. So, okay, what are we going to do about it? Small things, a little bit at a time, whatever we can do. And, Dakota said consumers, people should ask the nursing home what kind of access to licensed social workers will, the person have who's coming to live here. So very, very important. And, again, we work very closely also with the Medical Directors Association, which is now PultMed. And, these things, there's a lot of issues with medical direction as well. Again, we already talked about Nadana and working with directors of nursing and with groups like NACA, which are representing certified nursing assistants around the country. So, so thank you all. Alexa, did you have something else you wanted to chime in here? I don't know if we cut you off, sorry.
No, I was supporting what Mercedes was saying.
Okay, good.
Can I add one
Yes, of course.
to respond to Mercedes? So I think, one of the ways to look at it is, there's really a stepped care model of mental and behavioral health services. So at the bottom of that stairwell, we have things like activities. We have things like training for staff. We have a lot of things in place in nursing homes to provide that kind of basic level of psychosocial support. And then we do have technically access to high-level providers of, consultants, psychiatrists, or people doing med reviews, kind of those third-party companies that a lot of times we contract with that are at the top of that stairwell. What we're missing is the middle of that stairwell, and that's where we're misusing social work. There are a lot of psychosocial interventions for people with serious mental illness that have been tested on older adults that are skills building, communication skills, monitoring skills, things that we know work that we're not really giving because we don't have that mid-level, like middle of the stair provider embedded in the system. We're either saying we're doing this very low level dose, or we're giving outside referrals for people that are at the highest level of stairwell. So I think we need to fill that middle of the stepped care model.
And that would get us back to policy because we need to find a way to compensate those people. Again, we talked a little bit about that, but I think we do want to reflect and acknowledge that one of the challenges is it's really hard if you're a psychologist and you're going from nursing home to nursing home and it's Medicare payment, for your services. It can be difficult, or if you're a social worker or any of these other roles that people play. So I think, Isaac, if you want, you can take us off of Spotlight. I think we want to just really open it up to the group. Anybody who has a question they have not asked us yet, or anybody who would like to, suggest a program or a training or anything else that you're familiar with, be happy to just let us know if you want to come off of mute, if you are not able to come off of mute without us doing that for you. We have some national people. We have Ella Taggart from Nashville on the call. I know we do work with that group as well. We've got a few other people who work with, the culture change coalitions and different groups they're doing some of that work. We have a few people who are nursing home residents who are on the call, and many others. So what have we not? We have activities, people who are recreational therapy directors. And we have people from the GWEPs, I see, from the Geriatric Workforce Enhancement Programs, which are launching their new work. So if you raise your virtual hand, we can recognize you and unmute you.
I have a question for the attendees. What are the issues you're facing in your nursing homes, and what brought you today? What answers were you hoping to find?
Clayton chimed in about a resident peer support program, 100% paid by CMP, civil money penalty grants. So that's another really good, approach. We've Michelle chiming in about being a family member.
A question or comment from Charity.
Okay.
Hi, actually, I'm here with Charity. My name's Tommy Liu. I'm a social worker at a facility here in Loveland. I just have a question about, and I think I've noted it a few times while you all have been talking, but really being able to create the trauma-informed behavioral health specialist level of care here, whether partially through building on CNA training to at least embed it within that kind of training, as well as social services, or a level of just a specialist. I know, like there are in homes, specialists that are out there. They're not necessarily licensed, but they are behavioral health specialists. Have you all been doing any work within all that?
I'm going to kick that question over to Paige, because I know that's one of her areas that she works in quite a bit. Paige, do you want to start us off about that question about trauma-informed care? Social work?
Yeah, no, I think it's great. I jotted a quick note to myself. The way I conceptualize it is trauma-informed care is a group of principles. There's some very specific things to do, right? So if I were to say to staff, well, do you think you provide a safe environment, emotionally, mentally, psychologically safe environment, physically safe? Do you provide an environment where you foster trust and transparency? And I think our tendency is, because healthcare staff we come to provide care. And so the quick answer would be, yes, we would do all of those things. But then the question is, but how do you do them? What does it look like? What does it sound like at the bedside, at the point of care? So I think for me, the framing that I love to use is trauma-informed care is the principles, nonviolent communication is the practice. That is the how. Those are the skills and the tools and the framing that help me. And when I teach, that is how I help to make the trauma-informed principles come alive. So to me, a lot of the training would start right there, would be developing. And again, I appreciated your point. It doesn't necessarily have to be a specialist. Remember, becoming trauma aware is something all of us can do. Every single person in that nursing home environment, every single person, every department. And I think a couple other things would be helping people to understand. One of the things we can do for staff is to help create a space that what I teach about is called impact sharing. So when we have people, like somebody had said, Alexa or Mercedes is talking about serious mental illness, working with these individuals is very emotionally taxing. It can be really draining in many, many different ways. And so we're talking about a collective workforce that is already stressed and distressed and traumatized for many different reasons. And now they're in a work environment. And the impact sharing concept is where we have trained individuals in the workforce where we can go to talk with them, whether it's a supervisor, a team, a collective, that we can talk about what's happening without being met with, well, you should have, or why didn't you, or the policy is, but truly receive genuine empathy in the moment where the person is, and then ask them, what is it I need to do to support you to help move to the next step with this individual, using our collective know-how to come to some more creative solutions. So those are a couple of things I wanted to say.
Fantastic. And there's still a lot of really good conversations in the chat. And Cindy Napolitan is one of our longtime nursing home residents who's part of Moving Forward Coalition. And she talked about, that the social worker where in the nursing home where she lives is very, very overworked. Before we wrap, a couple of things. One is I see Dr. Jane Carmody has joined our call. She's our Senior Program Officer at the John A. Hartford Foundation, our generous funder. And Jane, we were sold out today, so there you go. This is
Well, I saw
clearly
that, Alice, and I was trying to get in, and so I sent a note to Isaac, and I said, Isaac, I can't get in. And I'm sure I registered, but anyway, oh, Alice, this has just been a great conversation, brings back so many memories. I come from a health system in the middle of the country in Nebraska and Iowa, and I cannot tell you how big of an issue this is there, and how many people that we served that in nursing homes that really needed serious mental illness care, and the nursing homes trying to accommodate. Alice, I was particularly interested, thank you all. Thank you for the great work and the ideas. I was particularly interested in your comment about practice maybe first, then policy. So I know that can go around and back, but I think in today's world, we may have to really concentrate on practice.
Yeah, I think we've got lots of opportunities for both of those things, but really appreciate that. And I want to thank speakers today. And I just want to put a thought out there for everybody who called in today, speakers and attendees. What do you think about this topic as something? Is this a topic that you'd like to see continue on with some work groups, or, you know, again, it might be through other organizations. It might not be through Moving Forward, or maybe it will be, but there's a lot of groups working on this around the country. We know that, but just the focus on nursing homes and the focus on the changing population that we all talked about today. We'd love to hear back from you. So email myself or Isaac, let us know what you think, because there's clearly a lot of interest in this particular topic, I would say. Isaac and I also just wanted to let everybody know that the next coalition conversation is on December 11th at 4 p.m. Eastern, and it's on person-centered care training that we did in the state of Michigan with nursing home surveyors, and that we're still kind of doing through some webinars. And so person-centered care, if it's an interest of yours, and surveyor training is an interest of yours, please join us for that conversation. We'd be really interested. Isaac, anything else from you? Any other final thoughts, or from anybody else on the call today? Final thoughts on this topic or anything else?
One thing you can do today is invite a mental health expert in your community into your nursing home to give a talk about different kinds of serious mental illness. What is schizophrenia? What are psychotic disorders? And open that up to your staff, to your residents, to the families, and to the community, because it starts with some basic understanding, and then anything you can do to support those direct care workers, that's in the best interest of everybody.
Couldn't think of ending on a better note. That is absolutely perfect. Invite a mental or behavioral health person to come to the nursing home and show them what it's like and what they can do and what we can do with them. So again, thank you all so much. Send us your ideas for these conversations. We love to hear them. We follow them. And everybody have a great rest of your day. Thanks to all of our speakers.
Thank you, everyone.